No more cigar. Only when Arnold is there. He actually literally had the capital. We go to some point, look at one. So, Alison. Good evening, everyone. Good evening. Welcome to our evening of caring. We're very happy to have so many people here tonight. So much energy in the room. We're very excited to have you all here. My name is Bill Mejia. I'm the Cancer Support Services Director at the Lucy Curci Cancer Center. So we have a wonderful evening planned for you. I just wanted to mention a few things. At the end of our program, we're going to have a raffle for a wonderful gift. Sure, it's a beautiful purse, but anyway, it's going to be at the end. And then also we have excellent speakers tonight. If you have any questions, go ahead and write them down on the card, and we'll have a few minutes to during this to answer some of these questions. So before we get started, I just wanted to introduce our physicians for tonight. First, we have Dr. Mark Genesen. Say hello so people know who you are. He's board certified in gynecologic oncology. His education, training, and full-time faculty positions include Vanderbilt University, Northwestern University, Feinberg School of Medicine, and LAC USC Medical Center for Women's and Children's Hospital. Dr. Genesen focuses both minimally invasive surgery as well as radical surgery techniques, and is highly skilled in using the robotic Da Vinci surgical system to treat gynecological cancers. Next is our own Dr. Manasa Vulchi. She's right there. She's in the black. She gets very shy, but when she comes up here, she won't be, I promise you. She's board-certified medical oncologist. She completed an internal medicine residency as chief resident at MedStar Union Memorial Hospital in Baltimore, Maryland. She then completed a fellowship in hematology and medical oncology at the Cleveland Clinic's Taussig Cancer Institute in Cleveland. Dr. Vulchi specializes in breast cancer treatment and sees patients at our Lucy Curci Cancer Center in Rancho Mirage and the Arduous Health Center in La Quinta. And then we have Dr. Sarah Maher. Yay. Yeah, there you go. They want to know who you are. She's a gastroenterologist with Eisenhower Medical Center, Mirage Endoscopy Center, and Rancho Mirage Surgery Center. She received her medical degree from Ross University School of Medicine and has been in practice for over 11 years.
Over 4 years. Yeah, but I graduated medically in 2015.
Oh, okay. I can't add that, but it's a good enough. It's a lot of years. She has extensive experience in pancreatic disease and esophageal disorders. And then we're also very pleased to have Dr. Joan Dabu. Just raise your hand. There you go. Is a pulmonary disease specialist here at Eisenhower Health with more than 11 years. That's what we decided, right? 11 years of experience in pulmonary disease, interstitial, that's what I said, lung disease, and obstructive lung disease. She received her medical degree from the St. George's University School of Medicine and specializes in critical care. So we'll go ahead and I'd like to introduce Alison Sachs, who will come up and do some more introductions or more information. But I also want to thank Alison for putting this on from afar, and also to Cheryl, Ceci in the back, and her crew all around her for all their work tonight. So anyway, Alison, it's nice to have you back.
Hi. I always get nervous in the microphone with my big voice. First of all, thank you, Dr. Maher. She had said, Alison, your phone's going off. Turn it off. Would you all please turn off your phones or put them on vibrate? I appreciate that. So, welcome. I am so delighted to be here, especially because I left North Carolina where we had 3 inches of ice storm. My home is here and my driveway is here up the mountain. So I didn't know that I would make it, but I did. And I'm fortunate, and thank you, Bill, as you can see, to have a wonderful boss who brings me in. So I'm very delighted to be here with all of you. Before I speak a little bit about this evening, I would like to ask just one thing. By a show of hands, how many of you it's your first time attending this Evening a Caring event? Wow, Bill, look at that. That's wonderful. You oldies, I'm thrilled to see you. But that is really wonderful. Well, kudos to you all, because you're information seekers and you've come to the right place for that information, and that's really important for your health and well-being. So thank you for being here. And I'd like to share a little information if I can. So at Eisenhower Health, we really are proud to serve the Coachella Valley. We are the region's only nonprofit health system, and we're deeply dedicated to providing not only exceptional care, but also the information and education and support our community members deserve. That's why we're here tonight, and that's why you're here. So for over 15 years for this event, we've come together to focus on the importance of women's health, cancer awareness, and support that makes such a difference for all of you and those that love you. We stay true, at least we try to every single day, to Eisenhower Lucy Kirchie Cancer Center's tagline, a healing place like no other. Tonight's about learning and connecting and empowering one another with knowledge and hope. So I want to tell you why we did this evening and why our incredible providers, our physicians, agreed to join us and share information. America received both good and bad news in 2025 in our annual United States Cancer Report that the American Cancer Society puts out for us. The good news: fewer people are dying from cancer. The overall rate has dropped 34% from 1991 to 2022. That's the earliest or the latest statistics they're able to gather. That's extraordinary. So let me say that again. The overall rate has dropped 34% from 1991 to 2022. And that's thanks to improvements in detection, in treatment. Smoking cessation efforts have played a big deal. Now for the bad news. Cancer rates in young and middle-aged women are rising, past those of men in the same age group, but especially among women under 50. Their cancer incidence, women under 50, their cancer incident rates, meaning when they are diagnosed with cancer, are now an alarming 82% higher than their male counterparts. So let me say that again. Women, younger women, under the age of 50 mostly, their cancer incident rates, according to the American Cancer Society, are now an alarming 82% higher than their male counterparts. So the main takeaways, cancer diagnosis is shifting from older adults to younger adults, from men to women. So that's why you're here tonight. We're going to listen, we're going to learn, we'll be empowered by the knowledge our experts are going to share with us. They are trusted experts, and they will share the latest information, answer important questions, and help guide us in understanding the best steps we can take, all of us, as we move forward. Whether it's through prevention, early detection, or supportive care, tonight's all about the tools, making informed decisions, and supporting each other and all the women in our lives. Thank you all for being a part. Thank you all for being a part of this evening and for your commitment to caring about women and cancer. And I am delighted to be here. And thank you for having me, Bill. Oh, sure. I'd be happy to. You forgot, right?
I did forget.
Bill gave me an aside in case you didn't see. We wanted to share with all of you, there are quite a few men in the room, thank you for being here, that we took this event, which we've had, as I said, for so many years, so successfully, and we have fashioned an event for men that we will be offering Thursday, March 19th, about prostate cancer diagnosis, prostate cancer prevention, newest research, health issues, sexual health, because don't let anyone tell you there are no side effects after prostate cancer treatment. There are. That's the honest truth. So how do you cope with them? What do you do? Because there's lots of ways to do that. So we're very excited. Look for more information. Bill goes on TV and shares info. He's very good at it. And we hope you'll join us for that event. We hope you women will come and support the men for that event. So with that, I will invite up Dr. Mayer. Am I saying your name correctly? Is it Maher? I apologize. I'm Mayer. I'm Alison Mayer. Okay. Dr. Maher will be joining us. Thank you, Doc.
Good evening, everybody. Can everybody hear me just fine? I have a pretty loud voice naturally. Well, thank you so much, Alison, for putting this together. I am very, very excited to see so many people here. This is my first time presenting at this, but this is a really good turnout. And I love the theme of the evening because I think education is so important. It's so crucial to make wise decisions about your overall health. And I have the pleasure of talking about a cancer that I am very passionate about. It's what I see quite often, what I deal with all day, every day. And colorectal cancer is preventable. And so let's get into it. So let's first talk numbers, figures, and also prevalence in the population. So why do we even care about colon cancer so much? We care about it because it is the third most common cause of cancer, third most commonly diagnosed cancer in both men and women worldwide. It is the second most common cause of cancer-related death, or mortality is the medical term for that. And that number is also worldwide, so it is up there. For this year, in 2026, it's projected that we're going to have just under 160,000 new cases of colon cancer. And as for the deaths, it's projected that we're going to have just over 55,000. And those numbers have steadily been growing. So this study by the New England Journal of Medicine has basically highlighted that from 2000 to 2021, we have seen a 2.1-fold increase in the incidence or new diagnosis of colon cancer. And in females, as Alison kind of alluded to, we have actually been seeing a higher rate of increase compared to men. So 2.3-fold increase in females compared to 1.9-fold increase in men. Now, the risk of developing colon cancer increases with age. So the older you are, the higher a risk you have of developing this cancer. But very alarming and recent information is this is actually hot off the press, came out, published January 22nd. So a few weeks ago, in the Journal of the American Medical Association. The rates of colorectal cancer have been increasing, and I'm going to go through a few of these tables. So down here we have from 1990 to 2023. This is the most recent data that we have in males. And then here we have the numbers in females. And so colon cancer is the red line that you see in both tables, in males and females. Now, what you can see the trend, I know we're not focusing on gentlemen tonight, but I do see a few of you out there. The overall trend is you're seeing colorectal cancer rates increasing steadily. Same goes for females. So when you combine the data for both males and females, you get this table up here, which is looking at the overall deaths from the top 5 causes of cancer. And so lung cancer used to be number 1. Colon cancer back in 1990 was actually the 5th leading cause of cancer-related death. But guess what? It's been going up and steadily increasing. And now as of 2023, it is the number 1 cause of cancer-related death in people under the age of 50. You hear about celebrities all the time that get diagnosed from colorectal cancer. I don't know if anybody saw the news yesterday that came out about James Vanderbeek, I believe is his name, only 48. Chadwick Boseman, the lead actor of Black Panther, also died at a very young age. And so why is this happening? So we don't have an exact reason why. We do know that there are certain patients that are at increased risk. If you have a family history, you're definitely at increased risk. If you have certain conditions such as inflammatory bowel disease or a hereditary condition such as a condition that predisposes you to colon polyps, that will also increase your risk. But what is it about our patient population that we're seeing an increased rate in younger individuals? Interestingly, we see that Western populations have higher rates of colon cancer in younger patients compared to Eastern patients. What is it? It's lifestyle factors. So obesity plays a huge role. Sedentary habits, so people just not being as active. A Western, well, they call it a Western diet. Red meats, processed foods, high in sugar, high in fats, refined grains. This all plays a role. And then smoking and alcohol also seems to play a role in developing colorectal cancer. So all of these factors put together, it's believed that this alters your gut microbiome, your natural gut bacteria. And it's proposed that this leads to chronic inflammation, which leads to cell turnover and changes in eventually colon cancer. So I've just given you guys a lot of really depressing information about the increasing rates, but there's good news-ish kind of out there for women. I know there's men in here, but this table goes through some basic numbers and facts about colorectal cancer in males versus females. So overall, us ladies have a lower incidence rate compared to men. That incidence rate is increasing higher than men, but overall we have a lower rate, 41.5% in men to 31.2% in women. Similarly, mortality or deaths from colorectal cancer, higher in men compared to women. Overall risk, slightly higher in men compared to women. Rectal cancer risk, much higher in men. And hormonal influence. So testosterone seems to play a role in developing this cancer. Estrogen is actually protective. Men have lower survival rates, whereas women overall have better survival outcomes. So now we're going to segue into an image that I love to go through with my own patients when they see me in the clinic. If you're seeing me for a routine colonoscopy, if you're seeing me for that and I don't get to this, it probably means we spent a lot of time talking about other stuff. But this image basically goes through how one gets colorectal cancer. How do they develop it? So if you'll follow along from, this is start to finish. So these two over here are full-blown colon cancer. Over here, you have what's called a polyp. You guys have probably heard the terminology polyp before. What is a polyp? So a polyp is abnormal tissue growth. And polyps are essentially like moles within the lining of the colon. When I go inside and perform colonoscopies, that's exactly what they look like. And most of the time, in the beginning, they're just a few millimeters in size. And over time, most polyps are precancerous. Not every doctor will use that terminology, but most of them are precancerous. And over time, they will grow and grow and grow. And eventually, the white that you see is cancer within the polyp. So to go from here, where it's just a few millimeters in size, to full-blown colon cancer, which is these two, is roughly about 10 years. So it's a slow-growing cancer. Now we're going to get back to this image after we go through the various screening modes so that you guys have a better idea of what these different screening tools actually look for. Now, signs and symptoms of colon cancer. Guess what? Most of the time, people don't have any symptoms. Now, when we do perform screening colonoscopies, 55 to 60% of patients that we just find a colon cancer when we go in, they didn't have any symptoms. The advanced polyps, which would be like these bigger polyps over here with advanced precancerous tissue, those percentages are even higher, 72 to 77% didn't have any symptoms. And those are polyps that are kind of on the verge of turning into cancer. What I tell a lot of patients that come see me is don't wait for symptoms to get screening done, because oftentimes once you get symptoms, it's kind of too late. It's already spread all over the place. What are the most common symptoms? Rectal bleeding, abdominal pain and discomfort, changes in bowel habits, iron deficiency anemia. I see patients all the time. Dr. Vulchi always refers her iron deficiency anemia patients to me, or unexplained weight loss. So if you have any of these symptoms, don't wait, run to see a gastroenterologist to get checked out. So pop quiz for everybody out there. When do we start screening for colon cancer? 45? You guys are actually a really good crowd. What did you say? So, okay, I was hoping people would say 50, but you guys are a really smart crowd. Huh? Oh, you said 50. Okay. So it used to be 50. As of May of 2021, like right before I started practicing, the age was lowered to 45. Quite honestly, I wouldn't be surprised if they lower it further with the new data that came out. So how often do we screen? What ages do we do it? So between ages of 45 to 75, we really do it no questions asked. Once you're in the 76 to 85 club, which here in the desert, we got a lot of mature patients, and we do it on a case-by-case basis. So I tell patients, if you're generally healthy, you don't have any other cancer that's spread everywhere, you're not on dialysis or oxygen, then there's definitely benefit to continuing with screening within this 76 to 85 age range. Once you're 86 and above, you graduate from colonoscopies. You did it. You won the game of life. You don't need to go through this anymore unless you have symptoms. So there are high-risk patients. I noticed some individuals mentioned age 40 or 35. So when do we start it earlier? If you have a first-degree relative with colon cancer. So first-degree relative, you start at age 40 or a decade earlier than when they were diagnosed. So say your mom had colon cancer, she was say 45, then a decade earlier would be 35. I don't have that on here, but if you have two first degree relatives, oftentimes we'll do it sooner. And then if you have a history of inflammatory bowel disease, we always do it sooner. Or if you have a genetic condition, which I actually have so many patients with genetic conditions, I get a lot of referrals for these too. We will do it much sooner depending on what genetic condition. So what are the screening options? We're going to go through these briefly. So we have them classified in tiers. We have tier 1, which basically we have the most evidence. We know that these are really, really good screening tools. And the big thing about a screening tool is we want to catch colon cancer. Tier 2 is there's still good alternatives. Really, you should be turning to these alternatives if you aren't doing a tier 1 option. So I'll kind of go through some of these. There is the blood test, the blood DNA test, which does not have a tier classification as of yet. And so this is an option if you're saying no really to everything else. But I understand Dr. Genesen told me that we're going to have a separate talk on the blood test coming up. Wonderful. Okay. So let's talk about the stool-based tests. You guys have probably seen there's commercials for the poop in the box. That's the Cologuard. That's a tier 2 way of testing. And then there's FIT testing, which is another stool-based test that's done annually. So FIT is annually. There's something called high sensitivity FOBT, which is annually, or the Cologuard, which is every 3 years. And we're going to get into what these tests look at once I go through all of these. There's imaging-based testing. This is something called a CT colonography. And the downside to this is you still have to do a full bowel prep. So I say if you're going to do a bowel prep, just get the colonoscopy done. Because if this is positive, guess what? You get to do it again and get a colonoscopy. Okay, now colonoscopy. That's what we do, the gastroenterologists. So the great thing with the colonoscopy is it is both diagnostic and therapeutic. So we're able to find the polyps. We can take care of them right then and there. A lot of people have a lot of anxiety leading up to the colonoscopy, and I personally have not had one done, but from everybody that has, most people say it's the prep that's the shitty part. Sorry. The procedure itself is a piece of cake. It's the best sleep ever. You've had it. It's great. People love it. It's over before you know it. And so, yeah, it's like a cocktail through your IV. It's really, really great. And so I'm going to talk about what these different modalities really look at. So the colonoscopy, you can find polyps of any size. And as a gastroenterologist, I really like when polyps are this size because they're a lot easier to take out. Less risk, less bleeding, less infection, less risk of a perforation where we poke a hole in the colon. Now, the other tests, actually all of the other tests, are really picking up on the bigger stuff, which, you know, it's not going to miss it, but it's not where we really like to intervene. So the CT colonography can only, the CT scan you have to prep for, can only really pick up on things that are a centimeter or bigger. The stool-based testing, they look for abnormal DNA in the stool, and they're really going to catch full-blown colon cancer or more advanced polyps. The other thing is, if any of these tests are positive, you get a colonoscopy. Now, if you are at higher risk, so you have family history or inflammatory bowel disease or a genetic condition, guess what? The colonoscopy is the recommended screening modality. So the big thing is early screening saves lives. Colorectal cancer, apart from those fluke cases of people diagnosed at 20 or 30 years old, is preventable. We prevent it by catching it early in these small stages, cutting it out of there, and it doesn't grow into anything. So this was a really sad fact I stumbled upon when I was building these slides. California, compared to all the other states in the US, is the worst in terms of screening. So we have the lowest rates of patients that are eligible for screening that actually get screening done. We're 53%. And I want us to bring those numbers up, starting with you guys, hopefully. And this includes any screening modality. So stool-based testing, CT, blood, whatever, you name it. So how do you choose a screening option? Well, you can start by talking to your primary care provider. They know a lot about all of this. Or you can schedule an appointment with your gastroenterologist. We have a bit more information to give on this. And here is my group, the Eisenhower Gastroenterology Group. There are 7 of us. There's only 2 of us females, myself right there, Dr. Mehta, and then these 5 wonderful gentlemen. They're all really, really great. And then we also have 4 nurse practitioners with our group. Michael Valdez, he actually just recently joined our group, but yeah, we have a really, really great team. We also have a way to bypass the clinic, that if you go through your PCP, they order the colonoscopy. If you meet certain measures, you don't even need to be seen in the clinic. You can just schedule your appointment through MyChart. So bottom line, some key take-home points. Colorectal cancer is the 3rd most common cause of cancer worldwide and the 2nd most common cause of cancer-related deaths. And upsettingly, it is now the #1 cause of cancer killer in adults under 50. And the rates are rising faster in young women compared to men. And here, lifestyle and diet really, really matter. So maintain a diet high in fiber, lean meats, vegetables, exercise, limit your alcohol and smoking. No, don't smoke at all. Limit your alcohol intake, and screening really saves lives. So 45 for average risk. And if you have a family history, if you're not sure if you qualify for an earlier screening, just come and see us. We'll be able to go through all this with you. So you have choices. There are so many screening measures. There's no reason why nobody should get any sort of screening done. And make sure you watch out for symptoms: bleeding, pain, changes in bowel habits, unexplained weight loss, iron deficiency, and anemia. If you have any of those, make sure you see one of us. And don't wait. A point that I didn't make earlier, but part of the reason why we're seeing this in younger individuals is a lot of times when they have symptoms, they kind of just brush them off like, oh, it's probably hemorrhoids. I've seen that so many times. Do not take your symptoms seriously. So knowledge is power. Your health is in your hands, and take action today. So here's some resources for more information. I mean, there's so many resources out there. And thank you. So these are my babies. And I think, thank you. All right, Alison's coming back.
Hello, everybody. Thank you for having me today. That was a hard follow to act. I'm not as funny. But for my part, we're going to be talking about lung cancer in women. So why focus on women? Well, because it is the second leading cancer in women, and only behind from breast cancer. It is the leading cause of cancer deaths in women, accounting for about 21% of all cancer deaths. So it's very important that we recognize this. The US had the second highest number of lung cancer cases globally in 2022, only behind China. China had more reported cases. Thankfully, US lung cancer rates have been decreasing in men since the 1980s and in women since the mid-2000s. I think we attribute all of this to the smoking cessation programs that we've had implemented over the last couple decades. Although the decrease in lung cancer in women is at a much slower pace than men. So worldwide, there are greater than 600,000 women die of lung cancer this year. In 2025, here in the United States, about 116,000 women will die from lung cancer. Will be diagnosed with lung cancer, and 60,000 will die from lung cancer. Lung cancer claims as many lives of women in breast, ovarian, and cervical cancers combined. Yeah. And Asian women in the US who have never smoked currently are twice as likely to develop the disease than female non-smokers of other ethnicities. Yeah. And typically, the typical age of lung cancer in women is 65 years or older. The average age is about 70. It's very, very small number to develop any lung cancer for women younger than age 45. So women with lung cancer are more likely to be younger and have little to no smoking history compared to with men who diagnose with lung cancer. And although lung cancer diagnosis may be delayed in women, women exhibit higher survival stage for stage than their male counterpart. We attribute these to genetics, endocrine, and biological factors. Women who smoke are 25 more times more likely to be diagnosed with lung cancer and die from it than people who never smoked before. So that's very important key distinction that we need to remember, because that will affect our screening later on. these are the type of lung cancer that we see. We distinguish lung cancers as non-small cell lung cancer and small cell lung cancer. The most common type of cancer is adenocarcinoma. The reason why we make it, and non-small cell lung cancer is about 85% of all lung cancers that we see. The reason why we make a distinction is because treatment is very different. Non-small lung cancer tend to be a little bit easier to treat, so to speak, than small cell lung cancer. There is a little bit of variability in terms of treatment between these two groups. Risk factors, as you know, cigarette smoking, including secondhand smoking. So growing up, if our parents were smokers, that puts us at risk of developing lung cancer in the future. And it causes greater than 60% of lung cancer in the UK and about 86% in the US, according to American Cancer Society. And 20% of the lung cancer occur in never smokers. So it's something that we also have to remember. If you can see this graph over here on the right-hand side. So for patients who've never smoked before, so never smokers, their cumulative risk is about less than 2% developing cancer in the future. People who stop smoking at age 30, it's still about less than 5%. If you stop at age 50, we're still about less than 10%. If you continue to smoke, then those numbers can be as high as greater than 15%. So for people who do smoke, it's never too late to quit. As you can see that you decrease your overall risk of developing cancer in the future if you stop smoking. And unfortunately, it is the most difficult thing to do is to stop smoking because of the addictive property of the cigarettes. But we do have smoking cessation programs here in Eisenhower that can help us succeed in doing so. So who are the people who are non-smokers who develop lung cancer? Were those people who were developed with this, who were exposed to asbestos, silica, radon, air pollution, diesel fuel exhaust fumes, and people who have been exposed to both asbestos and cigarettes are 100 times more likely to develop lung cancer in the future. Thankfully, asbestos is not as prevalent as we used to, and we're sort of more aware of the risk of asbestos, so we're using more, PPEs or personal protective gears when we are dealing with asbestos. Also, if you have underlying lung disease, such as emphysema and interstitial lung disease, you are at a higher risk of developing lung cancer, even though you've never smoked before. Other cancers, if you've had other cancers in the past, such as breast cancer or colon cancer, you're also at risk of developing lung cancer in the future. And family history of lung cancer, you are at a higher risk of developing lung cancer in the future. So because of this, in 2002, there was a national lung screening trial where they recruited 54,000 patients for those who are high risk of developing lung cancer. So what they did is they did an annual low-dose radiation CT scan of the chest to detect early signs of cancer. And the data was published in 2011, and what they found is that it decreases mortality by 20% compared to chest x-rays. Well, who are these high-risk people who will develop cancer in the future? Well, people who are current smokers or former smokers who have smoked about 20-pack years. What is 20-pack years? Well, 20-pack years is if you smoked 1 pack per day for at least 20 years. If you smoke half a pack per day, you have to have smoked at least 40 years to qualify for the screening. If you are at the age of 50 to 80 years old, who fit into the criteria of 20-pack years and who are current smokers or quit within the last 15 years, you should get screened every year for lung cancer with low-dose radiation CT scan. The reason why we do low-dose radiation is to decrease your risk of exposure to radiation, because unfortunately, cumulatively, over the next 20 years, if we keep doing CT scans, there are risk of radiation exposures as well. And so that's why we decided to do low dose radiation, which is good enough to detect any early signs of cancer. Like I said before, like the colorectal screening, early detection and treatment improves survival. So that's key. And unfortunately, there's a paper that was published by JAMA in 2025. We are under screening our population. We are at about abysmal of 19%. We are not even close to capturing everybody who qualifies for screening. In California, just like in colorectal cancer, we are the third worst in the nation in screening our patients for lung cancer, at a screening rate of 16.8%. So we still have a lot of ways to go. So why is screening so important? Well, these are the 5-year survival rates as of 2017 by American Cancer Society, which shows that if you catch a stage 1 lung cancer, your 5-year survival could be up to 92%. If you catch it at a stage 4, your survival rate is about 10% or less. That is a significant reduction in survival if we don't catch it early. So that's why it's very, very important to screen early, screen on time, and screen annually. This is the same sort of slide that says if we diagnose early, more people will survive. Signs and symptoms. There are no symptoms in the beginning of lung cancer. You will not have any symptoms. By the time we have any of these symptoms like hoarseness or coughing up blood or shortness of breath or weight loss, it is too late. We are dealing with likely an advanced cancer like stage 3 or stage 4, where our survival from that cancer will be very low. How do we diagnose it? Our preferred way to diagnose and biopsy the lung is flexible bronchoscopy. Prior to the pandemic, there is this new technology called robotic bronchoscopy, which has made our biopsies more accurate. And at the same time, we can also stage it with endobronchial ultrasound, where we would biopsy the lymph nodes that are located in the middle of our chest to stage that lung cancer to guide our treatment. So our preferred method of diagnosis is flexible bronchoscopy with robotic bronchoscopy with endobronchial ultrasound for staging. We have 2 providers here in Eisenhower, Dr. Thomas and Dr. De Silva, who are able to do this for all of our patients. And it's a relatively safe procedure. We also can do CT-guided biopsy, where if you see here on the bottom, a radiologist would basically put you on a CT scan, and it would stick a long needle from the chest wall into the lung and biopsy that area of the mass. However, there is an increased risk of puncturing the lung. The lung is like a balloon, it's full of air. If we puncture the lung, it tends to get deflated. That's the main complication for doing lung biopsies. Unfortunately, it is a lot higher with CT-guided biopsies than the robotic bronchoscopy. And we have disadvantage of not being able to biopsy the lymph nodes for staging. So even if we diagnose lung cancer with CT-guided biopsy, we still have to undergo bronchoscopy to do an endobronchial ultrasound biopsy for staging. So we would like to do everything all at once with flexible bronchoscopy and endobronchial ultrasound biopsy. Of course, surgery can also do the same, although we would like to minimize any invasive procedure if we can. So these are the treatment options. So for early stage lung cancer, such as stage 1 or stage 2, surgery is our best option. That would give us the best survival. However, not everybody is a candidate for surgery. So for some of our patients who cannot tolerate surgery because of its invasive in nature and the risks involved, then radiation is a close second. For more advanced stages, we can do chemotherapy, although chemotherapy can have a lot of side effects. New medicine now, we have these precision medicine where we do targeted therapy where they would just attack the cancer cells to minimize the side effects of these treatments. Or certain treatments can also mobilize our own immune system to attack cancer cells. So there's been a lot of advancement in lung cancer and treatment of lung cancer. But the goal is to diagnose it early so that we can have better chance of survival. So in conclusion, lung cancer is a major public health issue for women. Smoking is the largest risk, but smoker disease is rising, and early detection greatly improves survival. We do have a lung cancer screening clinic here in Eisenhower over at the Hewitt building that your primary care doctor can refer you to for our patients who were former smokers or active smokers, so we can screen you properly for lung cancer. And there's 8 providers, 8 doctors in our lung clinic and our pulmonary clinic that can help us, diagnose and treat, of course, with coordination with our oncologists and thoracic surgery to help us treat lung cancer. And that's it for me. Thank you.
I'm going through your slides. Where's my, oh my gosh. Is that, oh. Well, we'll wait for my slides. I just today want to talk a little bit about cancer incidence in young women, breast cancer incidence, and talk about a little bit about high risk, who's considered high risk, and what can we do to detect breast cancers early, and how can we try to prevent cancers, especially in our high risk women. We'll just wait it out for the slides. That's okay. It's my fault. I gave him the slides very late. Do you want to? All right, now we have the slides. So when we think about breast cancer, we think about it as a cancer that develops mostly in our older women. The median age for diagnosis for breast cancer is 63. But breast cancers can happen in younger women too. About 10% of all new breast cancers happen in women under the age of 45. So over the past 2 decades, the incidence has been gradually rising. It's almost 1.1% per year rise since 2012 to 2022. In 2022, there were 27,136 new breast cancers diagnosed in women under the age of 45. That's a graph just looking at how the incidence has been gradually going up. Why is this happening? We think it's a whole lot of factors, not one specific factor that's triggering this trend. The obesity pandemic, weight leads to increased estrogen production because of the fat cells producing estrogen. So the increased incidence we are seeing in our younger women is mostly estrogen receptor positive breast cancer. So that explains part of it. Increasing alcohol consumption, sedentary lifestyle, early menarche, so starting a period very early in life, late menopause, so continuing to have periods into their 50s. This leads to longer estrogen exposure in the body over time, which can lead to increased breast cancer. Delayed childbearing to some extent can increase risk as well. There's a lot of emerging data about environmental exposures like endocrine disruptors, although nothing has, like microplastics and the food we take and pollutions, that kind of stuff could be responsible for part of this as well. What are the challenges in our younger women? We routinely start screening mammograms at age 40. The recommendation currently is to start at age 40 and screen annually. There is no end date specifically. There are some guidelines saying 75, but we typically say if a woman is active, healthy, no competing medical problems, that would take her life in the next 5 years or so to continue getting screening mammograms. And the reason for that is we want to detect these cancers early. It's when they are small, it's easy to take care of. Smaller procedures, typically very well tolerated, improves survival. But because we don't routinely screen our women under the age of 40, some of these cancers can go undetected. And these are the women that are diagnosed in later stages, where the tumors are much bigger or there's lymph node involvement. So treatment is harder, then there is more need for chemotherapy, things like that. Paying really close attention to symptoms. If there is a lump the woman has noticed, bringing it to medical attention immediately. One thing we typically see is around time of pregnancy. There can be pregnancy-associated breast cancer, which is very aggressive. And a lot of the times, people think it's a blocked milk duct and it will go away, and that keeps getting pushed back without a medical evaluation. So any breast lump needs to be evaluated immediately. We still, in this day and age, hear from patients that I did seek medical attention and I was told I'm too young to have breast cancer. So advocate for yourself, advocate for your families. These need to be evaluated. Other things with young women, a lot of them have dense breast tissue, and it's harder to find tumors on routine screening mammograms when breast tissue is dense. Something to pay attention to. And we'll talk about that in a minute as well. In our younger women, we do tend to see more aggressive biology, triple negative breast cancers, HER2 positive breast cancers, which tend to be faster growing, needing more intensive treatments. Genetics plays a role. We, in women with mutations like BRCA1, BRCA2, PALB2, things like that, we see a disproportionately higher incidence of cancers related to genetics in our younger women. So how do we define high risk? Average risk is considered 12% in the, on average, about 1 in 8 women develop breast cancer in their lifetime. So for an average risk women, their risk of developing breast cancer in their lifetime is about 12%. We consider it high risk if their lifetime risk is over 20%. Why does that matter to us, right? If they're at high risk, we want to think about starting screening early. We don't want to wait until they're age 40. We want to start with MRIs. We can even start them under age 30. And then at 30, we can add on a mammogram for them. We can do supplemental screening with MRIs for our high-risk patients. We can talk about risk-reductive medications, things like that, to prevent their cancer diagnosis. So who should be evaluated for high risk? People with family history of breast cancer, ovarian cancer, even pancreatic and prostate cancers. These are the people that should go to their physicians and talk about family history and get an evaluation. breast cancer in a male relative, all those patients need to have genetic testing and be evaluated. Ashkenazi Jewish ancestry, these people have a higher incidence of BRCA1 and BRCA2 mutations. And so genetic testing is approved even at a population level, something to think about. If they already have a genetic mutation that they know about, they need to be part of a high-risk program. Mammographically dense breasts, especially extremely dense breast tissue, is in itself a higher risk of developing cancer that needs to be monitored closely. If a woman had a previous biopsy that indicated a high-risk lesion, some of these like atypical ductal hyperplasia, for example, or lobular carcinoma in situ, things like that, that predicts for a higher risk of them developing a breast cancer in the future. So that needs to be monitored. If they had radiation to the chest between ages 10 and 30, like in the past, they used to do mantle radiation for certain lymphomas. These women are at higher risk. How do we calculate the risk? There are multiple risk prediction models. The one we currently use at Eisenhower is the Tyree-Cuzick risk model. What it takes into account is age of the woman, height, weight status, when did they start their period, when is their menarche, when did they go into menopause, their family history on both sides of maternal and paternal family. It goes all the way into the nieces and nephews level. And if they had genetic testing, it takes into account the genetic testing and gives us percentages as what is the lifetime risk. If you've had a mammogram or some kind of breast imaging done at Eisenhower over the past 1 year or so, we've started using or incorporating the Tyree-Cuzick risk model into our mammograms. If you look at the very end of the mammogram page, you will see this breast cancer risk assessment. It tells you what is Tyree-Cuzick lifetime risk. So I took this off of a mammogram report, and this woman has a 26.31% lifetime risk of developing breast cancer. So this is somebody we want to consider for a high-risk program and do close surveillance and think about risk-reductive medications. This won't be in the mammogram report, but your physicians will have access to the right side of the screen with the 5-year risk, 10-year risk, lifetime risk, and what is their possibility of having a genetic mutation. It's important for us to know the 5-year risk, because when we are thinking about risk-reductive medications, we think, okay, lifetime risk is more than 20%, but what is their more immediate risk? In the next 5 years, what is their risk of developing breast cancer? And if their risk is more than 1.7%, we do think about risk-reductive medications. So 2 things here. We want to detect early, and then we want to think about risk reduction. So for early detection, we do what we call high-risk surveillance for our women at higher risk of developing cancer, breast cancer. We want to do a mammogram annually, and then we want to add on a breast MRI for supplemental screening. We typically stagger them every 6 months for better, more optimal coverage. We want to do clinical breast exams every 6 to 12 months because there's still about 30% of people that are diagnosed from presenting with a breast lump. So all of these 3 are incorporated into the high-risk programs. Then we talk about lifestyle. Like with all other cancers, we want to think about regular physical activity, at least 150 minutes of moderate intensity exercise a week. We want to think about weight management. It's important to reach an ideal body weight because we know that fat tissue produces estrogen again, and that can lead to estrogen receptor positive breast cancers. Limiting alcohol intake, thinking about a healthy diet, all these can be helpful in reducing the risk. So risk-reductive medications. These medications, which are hormone blockers, can reduce the risk by about 50%. It reduces the risk specifically for estrogen receptor positive breast cancers. These are typically very underutilized because of fear of toxicity. However, if these medications are used appropriately in the right clinical setting and monitored carefully and dose adjustments and things like that, depending on toxicity, these are not chemotherapy, right? These are just hormone blockers, and most women can't tolerate them in the appropriate setting. So the options we have, if a woman is premenopausal, the only option we really have is tamoxifen. For our postmenopausal women, we can use all three of these classes, tamoxifen, raloxifene, or aromatase inhibitors. We usually assess to see what their risks are, what other medical problems they have, and we pick the right medication for each patient. So thank you very much for being here.
All right, we have about, I think, 45 seconds before you guys all get to go watch curling. Thank you, Alison. Has anybody watched curling? Downhill skiing? Ice dancing? Selective crowd, otherwise, if you were watching that, you wouldn't be here. Got it. Thank you all for being here. So what I wanted to do was give you a brief overview of the highlights, understanding that we've actually had great presentation about three really important topics by three folks who have done such a great job of contributing and building to what we've had here with quality. Dr. Dabu, guys, if you're ever sick in the ICU, you want somebody directing traffic, when you are on the edge of the abyss, she is it. And when you are lost and scared and you want somebody who has spent their professional career focusing on breast cancer, Dr. Vulchi comes from a world that has been building leaders for the future and has been a huge, huge addition in that regard. And then Sarah, next generation of that for the GI world. But before I go any further, it's not very often that a guy from Chicago has the opportunity to make a girl from New York blush. It didn't take much, did it? So much of what we do with cancer prevention and screening is about engagement. And my talk is a lot about engagement. And engagement is really about patient-centered care. We can sit here and talk till we're blue in the face about all this, but the reason why most folks don't get screened for lung cancer and all the other things that we're going to talk about is a lack of engagement. For the last 20 years, Alison Sachs has been pretty much the face of the cancer center. I would like everybody, actually, if you could all stand up and give Alison a round of applause. She had a vision. Alison had a vision 25 years ago when lots of money was spent, $40 million on bricks and mortar, but there wasn't a sense of program development. And what she knew she could do beyond the complicated stuff was she knew that she could engage the public, and that by engaging the public, she would help you all to prevent disease, get diagnosed earlier, and has continued those efforts. New York girls moved to North Carolina, and somebody sells them land where they have a steep driveway. She has been fortunate, and we've been fortunate enough that Bill has worked with her hand in hand so that she's continuing to help guide us to provide these venues for you all. So thank you, Alison. So what I wanted to do was briefly take you through what works so much for our world. Cervical cancer, which y'all don't think about much, but even if it doesn't affect you, the cost of your tax dollars that are spent and wasted on people with low advanced cervical cancer has incidence in East LA of anywhere in the country almost. A lot of the increased cancer incidences that we have in California is patients who don't have access. And you'd say, well, that's their fault, whatever. It costs us a ton of money. So it's really helpful for us to try and create public health plans in place to try and provide access. Cervical cancer is the prototype for effective screening for cervical cancer. As much as most of us, our generation, had the magic of discovery with, July 20th, 1969, we still get goosebumps when we think about watching Neil Armstrong land on the moon. I had the opportunity as a fellow to work with Dr. Zurhausen's lab and his key proteges as they were developing this genius connection between HPV infection in the anus and lower genital tract and cancer. And not only have they done that, but they figured out how can you develop a vaccine that's safe and effective. And with that vaccine, since about 2004 or 5, we should be able to eradicate about 95% of all cervical cancer in the world. Why don't we? It's a communication and engagement thing. People don't trust what they hear. They don't get the information that they need. And even if they do, implementing access to care for colon cancer screening, for lung cancer screening, for breast cancer screening just doesn't happen. And then even if they want to do all the things, getting them access to care, getting somebody to come back and follow up when they've had an abnormal mammogram, it's not easy. So in the cervical cancer world, they figured out, wow, we could do all these things. In Peru, they had a program. They even convinced the Shining Path terrorists who were creating industrial sabotage in the 1980s and 90s. We were a liaison of their cancer center. And they were wreaking havoc all over the country. They figured out a way to get access to the areas that the Shining Path terrorists had in rural areas to allow people to come in and get screened. The problem is nobody ever came back to follow up their abnormal pap smears, which led to the idea of a preventive vaccine. You come, you get one shot, you get another shot, and you're done, and you probably aren't going to have to deal with the other issues in the future. So what do we know does work beyond the wonder of things like the HPV vaccine? As we've talked about, weight management, diet and exercise. HPV vaccine is safe and effective. We know that pap smear screening with human papillomavirus testing is safe and effective for women with potential risk for endometrial cancer, which is soon to be by 2030, it is going to be the third most common cause of cancer in women, doubled in my lifetime. A lot of that you can simply diagnose by getting women informed and engaged. Come in when you have abnormal bleeding. If you're reproductive age, somebody puts you on oral contraceptives or hormones to cycle you, that's not working. You need an endometrial sampling. If you're over the age of 35 or as you get older, you don't do a trial of hormones, you go straight to endometrial sampling to identify that. And the sampling that they used to do in the office that used to be terribly painful and require a DNC in the hospital can now be done. Several of our providers are able to do not only a DNC in the office, but liquid little scope that has improved the sensitivity of detecting endometrial cancer and its precursors at an early stage. But people have to know and understand that they should come in, have access to get there, and then be able to follow up. And then lastly, after menopause, when I was a medical student, our chair was a well-known guy nationally. He made sure every student in my medical school class had a lecture from him on postmenopausal bleeding to understand the following. Postmenopausal bleeding is cancer until proven otherwise. Woman needs an endometrial biopsy. Amazing, guys, how common it is now that women after menopause see their primary care doc, even their gynecologist, and they just don't get that message. So great opportunity to help folks with implementing those things. What doesn't work? What most of all suffer some version of magical thinking, eating bad, not exercising, just putting your head in the sand. And then the trust thing, avoiding evidence-based screening, pap smears, coming in for abnormal bleeding. And then the really amazing to me, having been through the evolution of the brilliance, the development of the HPV vaccine. My junior fellow, when I was a senior fellow, did a presentation at the annual meeting of the Society of G1 Oncology that won best prize for the best scientific presentation in the world in the spring of 1995. And that was a proof of principle that you could develop a vaccine, you could develop an antibody response by providing folks an injection with what would develop the antibody response that would fight off the human papillomavirus in the future. It unfortunately took about almost 10 years to get to the vaccine to market simply because of family values, misunderstanding, politics, pharmaceutical companies being threatened that they would be sabotaged if they promoted promiscuity by recommending the human papillomavirus vaccine, which was just a misunderstanding. The other issue, and we've overcome that, working with family values folks, et cetera, that's gotten better, but we still only vaccinate about 50% of the eligible folks in the United States. More recently, what we've seen here in the Valley, we have any golfers? The senior tournament in Mission Hills is sponsored by a company that is, we'll talk about a little bit, that has promoted a blood test that it claimed could detect cancer. And we'll talk about that a little bit. And then the last item that's very common is, antioxidants and vitamins, et cetera. And none of those have really been found to be as helpful as they should. Again, things we can do to avoid, prevent cancer is tobacco we talked about. It's also a cofactor for HPV proliferation and cervical cancer. Maintaining a healthy weight, exercising, dietary recommendations that were talked about earlier. Less red meat, more chicken, more fish, avoid the stuff that we were all raised that we shouldn't do with lots of sweets, et cetera. Reducing alcohol intake, breastfeeding lowers your risk of breast cancer. HPV and pap smear screening, we talked about triaging abnormal bleeding, and then identifying the 5% of endometrial cancer patients who had a genetic predisposition, so then we can avoid, have that off the past and avoid them ever getting endometrial cancer. And for women with ovarian cancer, identifying women who have symptoms of pelvic mass. A lot of women with ovarian cancer, actually a subset, does have pelvic discomfort, symptoms of bowel or bladder changes that don't get addressed. But if they are early, they then might be diagnosed with earlier ovarian cancer. Unfortunately, 75% of our patients with ovarian cancer don't come in with that, and they have advanced disease. So we've had educational efforts for over 20 years now to educate providers and the public about that. And then fully 20 to 30% of our women with ovarian cancer had a genetic predisposition. And if we can identify that, we can then test them. They test positive. We can test their family members, do risk-reducing strategies until they're ready to have their tubes and ovaries removed, and then take out tubes and ovaries, and that's 99% successful. So screenings that we know do work. A lot of this is going to be repetitive because one take-home point to you guys to understand: Pap smears work. HPV vaccine is safe and effective. Endometrial cancer, we really need to do a better job of identifying, triaging abnormal bleeding, and then identifying our patients who are at a higher risk because of a genetic predisposition. And then the last item is birth control pills. Birth control pills actually reduce your risk of ovarian cancer by 50%. We've known that for a generation. Criteria for cancer screening that we've talked about: lung, breast, et cetera, today, and GI. You want to test to be able to detect a high proportion of disease early on with adequate sensitivity and specificity, safe to administer, reasonable costs, lead to demonstrated improved healthcare outcomes, which is all of the blood tests to date have not done that. Dr. Sai is going to talk about next month about how ctDNA might actually have a role that's evolving for colon cancer. And then these things need to be readily available for folks, and then we have to validate these tests. Things that don't work: total body scans, PET scans, routine CA-125s, routine pelvic ultrasounds. Test that was promoted from a study that was a really good study done in one of my homes at Northwestern from the Foundation for Screening and Prevention, the STEM Foundation, had preliminary data that looked like might be helpful developing a test for ovarian cancer, but unfortunately didn't pan out. And then the Grail Galleria test right now has actually been paused. There was a large study in the UK looking to validate it. All this advertising we've had, guys, for the last 2 or 3 years, it hadn't been validated. And they're advertising it and they're promoting it in our community. And those tests can do harm if people get a false positive, a false negative, et cetera. What we do have is some prospective trials that we're looking at to validate these tests. One is an alliance with the National Cancer Institute, and this is looking at obtaining blood specimens. They're going to look at various proteins in the blood of women who have known cancers of various stages. We are a site here. Dr. Sai's actually the principal investigator. Lainey, where's Lainey? Lainey has flyers if anybody is interested. This is kind of the right way to go about doing this. I can't tell you that this test is going to pan out, but this process the NCI is going through is the way that you identify and develop patterns of changes that could eventually lead to a test that really is a huge difference maker for us. So we talked about, we're gonna skip through the cervical cancer slides. World Health Organization has identified this as a huge priority. In many parts of the third world, cervical cancer is the #1 cause of death, in reproductive age women. And then we talked about the vaccine, getting people started when they're young at the appropriate age, PAPS work. So screening for endometrial and ovarian cancer. If we can identify a predisposition, all of our patients who have ovarian cancer, breast cancer now get screened. If you're screened and you're positive, your insurance is never going to be affected by that information. There's all these laws that protect you from any discrimination, employment-wise or insurance coverage-wise. We can then identify women, the 20 or 30% of women who are going to get ovarian cancer, and we can preemptively keep them from getting it by putting them on OCPs, some screening, and then when they're of an appropriate age, have completed childbearing, simply removing their tubes and ovaries laparoscopically. And we have a similar opportunity for Lynch 2 patients who have a cluster of colon cancer, endometrial cancer, also potentially pancreatic and other cancers. That we can identify them, we can screen them and keep them from getting cancer. As we've heard about all the rise in endometrial cancer or other cancers, endometrial cancer, this is mostly an obesity thing. We have 69,000 new cases a year. When I started doing all this, it was about 25,000 cases a year. It's mostly obesity driven. Some people are just, some of it's just because we're living longer, but this is something that is preventable. For For ovarian cancer, the most important thing to know and understand is that we don't have any validated testing. So be leery if you see tests. The FDA process is very imperfect for tests that get approved for screening. That is all evolving. Our website, sgo.org, AmericanCancerSociety.org are good resources if you have any questions about that. And you can be sure the first people are going to raise up and educate the public if we have a test for ovarian cancer, those are going to be folks in the women's health world. I wanted to just talk very briefly about the good things that have happened for our patients who have cancer over the last several years. We have collaborations now, not just in institutions locally, regionally, all over the US. Now it's international. So we have remarkable stuff happening in the world of lung cancer, breast cancer, cancer care in general. This antibody drug conjugate, it's basically a Trojan horse. You take a drug that's really active, you bind it to a protein that has high affinity only for cancer cells, another protein that gets you into the cancer cell, and then you get really high rates of delivery of cancer killer into the cancer that works approximately twice as good as the same drug when you just give it through an IV. This has been a major breakthrough in cancers across the board, including for us in endometrial cancers and others. And then for ovarian cancer, mirvetuximab, we're seeing the highest response rates we've ever seen in patients who are chemo-resistant with this antibody drug conjugate. Immunotherapy has revolutionized the world of cancer care. Should have worked really well based on the science for ovarian cancer. We've learned it's more complicated than that, but does work really well for our endometrial cancer patients and cervical cancer patients. Still working on trying to sort out why it's not working for ovarian cancer. This is just a quick timeline. To the left is based in 1960. You go to 64, the middle of the slide is 1990, and then look to the right of the slide. These are all new drugs that have been developed. We had a huge surge in the 1990s. Things were quiet for about 10 or 15 years, and then because of funding for the war on cancer, for the cancer moonshot, we had all of this funding to do international collaborative trials, and we've had all these drugs developed. This is just a quick list of all these new studies that have been done internationally over the last many years that have led to our international standards of care. And then this is just a slide talking about what we're looking about for endometrial cancer patients. We used to look at the grade of the tumor, how deeply it's invading into the muscular wall, and a few other things, and then determine how they were going to do afterwards. And subsequently, now we have all these molecular markers that we look at that are helping us better personalize and tailor everybody's care. This is a slide of drugs that we no longer, that have all been studied just in the last several years to give an idea. There's so much research going on. These are drugs that didn't work, but led to the development of all these other drugs that do work. So what do we need to do? Thinking about back to what we talked about, getting access. Talk to your primary care doc for your children, grandchildren. HPV vaccine is safe. It is effective. It doesn't make you more promiscuous. It does the opposite when you talk to girls in middle school about sexual health and preventing problems. There's all this data in that regard. Again, what works is diet, weight management, exercise, HPV vaccine, the PAP, triaging bleeding, and genetics testing. And again, the magical thinking, eating bad, avoiding of evidence-based screening, avoiding PAPs, and avoiding HPV vaccine, the miracle vitamins, and the unvalidated blood tests. What do we do next? We're working really hard, guys, in lots of different spaces on improving access. And with that, I want to thank you all for your time and attention tonight. Well, you shouldn't even have to bring out the hook.
Can you hear me okay? No. Thank you. How you doing?